Good afternoon. Welcome. I'm so very grateful that you've joined us here once again today. I am Alina Dorian, the Associate Dean for Public Health Practice, as well as Equity, Diversity, and Inclusion at the UCLA Fielding School of Public Health, but I've also been a school principal for 10 years. I'm excited that you're all here today for the second of a series of webinars titled Principal Practices for Safe Schools. I want to quickly take a moment to thank our collaborating partners, the UCLA School of Education and Information Studies, the California Safe Schools for All team, the California Department of Education, the Association of California School Administrators, and our California Connected Consortium, consisting of the California Department of Public Health and our academic partners, UC San Francisco. As you all know, the state's Safe Schools for All team released new guidance for school reopening in mid-January, and under that K-12 consolidated framework, the state provided detailed guidance around the school COVID-19 safety plan and its two main components, the school guidance checklist and the Cal-OSHA COVID-19 prevention plan. Today, we're lucky to have with us insightful public health experts, as well as our panel of incredible educators, esteemed school administrators who will pose questions to create a dialogue to better inform, empower, and create confidence in the decisions we need to make to open our schools and to keep our schools safe. So we'll begin today by hearing from our public health experts and then transitioning into our Q&A from our education partners. We're going to try and keep a bit of time at the end to address some of your questions. Please use your Q&A button to enter your questions, and thank you for those who submitted questions ahead of time. All of your questions and comments are valuable, and they're going to help us design the rest of this series. So without further ado, let me introduce our guests, beginning with our public health experts. We are so very honored to have with us Dr. Naomi Bardach, who since December has been serving as the California Health and Human Services Agency's lead for the multi-agency Safe Schools for All team. Dr. Bardach is also an associate professor of pediatrics and policy in the Department of Pediatrics and the Philip R. Lee Institute for Health Policy Studies at the University of California, San Francisco. We're also joined by our own Dr. Shira Shafir, associate professor in the Departments of Community Health Sciences and Epidemiology at the UCLA Fielding School of Public Health. She's also the director of the Master of Public Health for Health Professionals program, is an infectious disease epidemiologist, and is currently leading the monitoring and evaluation arm of the California Connected Partnership with UCLA, UCSF, and the California Department of Public Health to help build and train California's COVID-19 contact tracing and case investigation workforce. We're also very honored to have our incredible school administrators. With us today, we have Ms. Susan Montaño, principal of Ricardo Lizarga Elementary School in South Los Angeles. Ms. Montaño was born and raised in the Pico Union community of downtown Los Angeles, a bilingual daughter of immigrant parents, and a proud LAUSD graduate. Pursuing equity and justice for the same community propelled her in her educational journey, where her vision for school transformation begins with leading with heart, along with nurturing relationships with staff, students, and their families. Ms. Montaño's daily goals and actions are based on creating a safe environment in which every student must connect, engage, and thrive. And finally, we have Ms. Yvonne Nelson, principal of Foothill Elementary School, a dual immersion school in the city of Pittsburgh, East Contra Costa County, where she has held this position for the past 6 years. Prior to becoming a principal, she taught at several elementary schools spanning 20 years in the West Contra Costa County School District. She's a proud member of the Principal Leadership Institute of UC Berkeley, shout out cohort 15, and the proud mother of 2. So once again, thank you all for being here. And now it is my great honor to turn it over to my colleague, Dr. Shira.
Thank you very much, Dr. Dorian. It is a pleasure to be here with all of you today. As Dr. Dorian said, I'm an infectious disease epidemiologist, but I'm also the daughter of a school teacher, and I'm a parent of a child who I am desperate to be able to go back to school as soon as it is safe to do so. If there's one thing that we have heard over and over again in talking to teachers, in talking to principals and other administrators, it's that your heads are spinning. There's so much information coming at you, and all of you care passionately about both student learning and student and staff safety. So our goal here today is to help stop the spinning a little bit. We're going to try and introduce some of the evidence base and what the science tells us about how it's possible for schools to open safely. As you might imagine, an infectious disease epidemiologist lately doesn't get to share a lot of good news. I feel like Debbie Downer in most conversations, but in this conversation, one thing we know, there's a tremendous amount of encouraging news, and the science supports ways that it is possible to bring students back for face-to-face or in-person learning and to do so safely. So with that, in order to help share some of the science that we currently understand, as well as some of the policies that science has informed, I'm really pleased to be able to turn it over to Dr. Naomi Bardach, who will walk us through some of what the science tells us about students returning to face-to-face instruction. Dr. Bardach?
Hello, thank you so much. I'm just going to share my screen so I can give you guys some slides. Here we go, put on slideshow. So we're going to talk today about school-based COVID-19 transmission, and just as Dr. Shafir mentioned, the sort of what we know, what the science base tells us, and also how that informs how to do safe in-school instruction. So just a couple of disclosures and acknowledgements, just like Dr. Shafir said, I'm a pediatrician and a parent, so I am deeply invested in my patients who are at San Francisco General County Hospital being able to go back to into the public school system. Many of them are suffering in many ways from not being able to do that. I want my kids to be able to go back to school. But I am also a physician and health policy researcher. So I also wear a hat, as does Dr. Shafir, I'm sure, we also think about the adults in that school environment. And it has to be a safe environment, a safe working environment, and a safe educational environment. So it's really helpful to continue to think about both those things and to help unify that conversation rather than sometimes it splits. And so I think it's important to sort of, in this acknowledgement, I'm always trying to say, I'm wearing both those hats. Even though I am by title a pediatrician. And then change is the only constant. It's true for COVID. Things change all the time. This is a talk I used to give when I was just at UCSF. UCSF associate professor, and the evidence is changing constantly. Now that I'm at the state, we're trying to stabilize things for you guys so that even if the evidence is changing a lot, we're trying not to change our school guidance too much, but it does happen that there's some changes to the guidance in order to reflect that evidence. So I'm here to try and help give some of the framework of what is our Safe Schools for All plan, and then also how does the evidence sort of inform that. So this is a plan announced by Governor Newsom in late December. It established the Safe Schools for All team. It brought together that consolidation of existing guidance for schools. It used to be sort of all over the web and the internet, and so we tried to bring it together in one consolidated document for folks. And the framework for the governor's plan is built on 4 different pillars. One is funding to support safe reopening. We know that there's a lot to be done. You guys know better than anybody else how much needs to happen to change things in the school environment. It can't be done without money. However, it also can't be done without providing some kind of actual also resources of what are the safety and mitigation things that you need. So personal protective equipment, which the administration has been providing, as well as actually standing up a very intensive school state-funded testing capacity that allows people to, if they would like to bring in that testing, that's actually another component of being able to do safe schools. And then the hands-on assistance. So we know we can tell you all the complicated things to do and we can give you some money to do it, but if we don't give some technical assistance about how do you do it, and not just the supplies, but also the thinking it through and how do we organize actually collaboration sort of like this, like allow people to talk to each other and share what you know already. That's another piece that we think is really important to helping people do the implementation. And the last piece is transparency and accountability, which we have a website now that shows who's open and where they're open, and we're working towards actually being able to put case data up there as well where an outbreak's happening so we can learn from that. So briefly, what is the pathway forward? We know that there's 2 guardrails when we're thinking about school and in-person instruction in the COVID-19 pandemic. On one side, if we open up too rapidly without safety mitigation layers in place, no masks, lots of kids packed into a classroom, poor ventilation, that is a good way to transmit the virus and make schools unsafe for everybody in them. On the other side, if we say the only way to stay safe is to not go out, not do anything, don't interact, don't go to school, that is going to lead to only distance learning. And as many of you guys already know, very, very hard for families, for students, mental health effects, physical health effects, lack of nutrition, lots of things that are really, really tough. It's the indirect effects, but devastating indirect effects of COVID-19 if we don't pay attention to that, including the mental health also for families and actually for teachers also who feel isolated and anxious. So the pathway forward is in between. We know that mitigation layers can help, the safety layers can help to make it so that schools can be safe. So that's the pathway forward. The pathway forward is not to go careening off the road and either being unsafe on one side or no in-person instruction at all on the other side. I just want to briefly sort of frame for you guys, this is the emotional and intellectual journey of COVID-19. You can see we started, and school transmission actually, we started early on thinking there is no way we should have schools open. It is going to just drive transmission all over the place. We're going to have infections everywhere. In around May, June, we began to see internationally, it looks like some schools were open and it seemed like maybe it wasn't so bad. And maybe kids don't seem to get as sick and they don't seem to transmit as much. Maybe schools could maybe kind of open. Maybe that's a good idea. And then in July, there was a surge and it made people extremely anxious and we didn't really know enough about how to keep schools safe. And so a lot of people leaned back, took their foot off the gas. There was a lot less momentum for opening schools. And then when we got to that dip in September, October, people weren't prepared to sort of say, oh, the case rates are down. This is a good opportunity to open schools, because we just hadn't done quite enough planning in the summertime. And then we had the surge. And so as we come on the other side of the surge, we do know so much more than we used to know. And so now's the time to be preparing and supporting and start opening schools, which I know a lot of people are doing. So that's sort of what we're here to do. The goals for today is, what do we know? And how does it inform in-person instruction now and even in the coming stages? So we know more than we did in March. And I like to give you guys the take-home points first, and then it all settles in a little bit better. This, as educators, I think you'll probably agree. Tell people and then tell them again. So children get COVID-19 less often and are less ill than adults. They do not seem to be major sources of transmission to each other or to adults. Transmission in elementary schools differs from high schools. Adult to adult transmission is actually the most likely. Therefore, it's also where we have the most control. We have this image of the children as being the viral vector. They're going to get me sick for sure. I'm going to walk in the door, coughing, sneezing. I'm going to get sick from a kid. In COVID-19, it's just different. Adult to adult transmission is where we need to worry about it the most in the school setting. And therefore, we can control our own behavior. Community prevalence is going to affect school-based cases. There will be cases that walk through the door in schools as the numbers go up and down, but not necessarily in school transmission if we have these key mitigation strategies in place: masking, physical distancing, stable groups, ventilation, hand hygiene, and then symptom screening and screening for exposure and surveillance testing. And we can get to this later on, but it's the layers together. So sometimes people say, well, maybe my ventilation isn't great. If you have the other layers, it just helps to prevent. It's the layer upon layer that helps to prevent that transmission. So briefly, for the science sort of understanding, why do children get COVID-19 infrequently and why are they less severely ill? It's because the ACE2 receptors are the entryway for COVID-19. You don't have to remember ACE2 receptors. You just have to know they're the doorway. They're how the virus that causes COVID-19, also affectionately known as SARS-CoV-2, that's how they get in. It gets into the body. It's the ACE2 receptors. And our ability to make those receptors varies with age. Elementary students make the ACE2 receptors less than middle and high school students, that make them less than adults, which means that if you have fewer doorways for the virus to get into your body, you have less disease and more mild disease. The other thing we know is that transmission among or from students is just not that common. It happens, but it's just not that common. So there's a case study, which is like a, one sort of story of a person that got, it's a published report, but it sort of tells the story in a compelling way. And then there's big numbers, which I'll say on the other side of the screen. There's a French 9-year-old with co-occurring influenza and COVID-19, meaning he had the flu and he had COVID-19. He went to 3 different schools. He had 80 different contacts, and they traced them all, and there were 0 cases of COVID-19, but there were influenza cases. So that shows, like, yeah, kids pass around these other viruses, but they're not passing around COVID-19. At least not frequently at all. In Australia, they had a study of 10 early childhood centers and 15 schools. And the take-home point from this is actually mostly about this. If you look at the numbers about transmission in the school group, is that you can see child-to-child transmission very infrequent. Child-to-staff is only 1%, staff-to-child is 1.5%, and staff-to-staff is 4 times higher than the child-to-child or child-to-staff. So it's not the end of the story, but it really helps us to understand it's the adult-to-adult transmission, which is where the action sort of happens. So why don't children transmit it as efficiently? Not great scientific studies on this, but there are practical considerations. They have smaller lungs, so they puff out less viral particles. They have less severe disease, meaning they just don't cough as much, which means they don't transmit as much viral particles out into the world. And children are shorter than adults. So to the extent that the respiratory droplets, which is how COVID-19 passes, to the extent those respiratory droplets go down, which many of them do, that they just go down for kids, and the kids are shorter than the adults, and so it doesn't go up to infect the adult. So the other thing is, how do we know? So we know some stuff about the physiology. I just explained to you, the body is different, the kids are shorter, but are kids getting COVID-19 or not? How can we get more data on that? And there's a very nicely designed study who looked at a whole large group of children who had a test for COVID-19. Some of them were negative and some of them were positive. And the children who tested positive were more likely to attend gatherings such as weddings, parties, playdates, and funerals, but were not more likely to have attended childcare or school in person. So that helps us to understand, okay, what is it that drives things? It doesn't look like it's school. Another study that helps to illustrate that or explain it again or in a slightly different way is that, and in a slightly more detailed way, is from North Carolina. It got published in December of this past year. Community rates were up to 29 cases per 100,000 per day. And actually, I've talked to the authors, it went even higher, up to like 90,000 after they finished collecting their data. And 25 cases per 100,000 per day is where we say schools can't open in California if they have not already been open. They did 3 things in their group of schools in 11 different districts. They focused on the 3 W's: wear your mask, wait 6 feet, wash your hands. They had in school 700 community cases. Remember I said there are going to be cases that come onto the school site. The key is transmission, blocking transmission. In those schools, there are only 32 cases of in-school transmission, and they could be tracked to clusters of how did that happen? 1 was due to no masking, 2 was in a special needs setting with eating in close proximity, and also some difficulty masking. And so they changed some of their policies after they figured out what was going on in order to address those things and decrease their ongoing risk of transmission. And there was no child to adult transmission. The other thing about that study is that the North Carolina residents during that time with COVID-19 were infected approximately 1 other person. So if the same number of transmissions were occurring in schools that were happening in the community, there would have been 800 to 900 cases in the schools. So that tells us schools are actually somehow safe, right? There's something going on there. There's a couple different reasons for success. One thing to highlight is the ability to share lessons learned peer-to-peer. So I think that's where these kinds of fora are actually very important. And the implications from the study are that mitigation strategies make a difference. They're the key to prevention, especially in high community rates. And the data suggests that schools are safer than the community if mitigation is in place. And I like to give the teachers and the students credit for this and the school environment. It creates routine, it creates a sense of peer group, and everybody wears their mask together. And teachers they're really good at creating, structure and helping people to sort of do things together. And so I actually think that that's a big piece of it as well. This is another study also from Wisconsin, which I won't go over deeply, but it's a similar kind of findings, which is that it was in K through 12 schools. They used masks. They had small cohorts of 11 to 20 students. They had 6 feet of distance, and they had very little, on the other side of the slide, they had very little, very few cases, 7 cases of almost 5,000 students and 0 staff cases for COVID-19 at school. This is the story of high schools being different from elementary schools. This is from early on in the pandemic. They looked at schools that were open with no precautions at all for a period early on in the pandemic in a county in France that had a lot of COVID-19. They knew the community prevalence at the time was 9%, and they did a study of people's blood to see, like, did you ever get COVID-19? It's called the antibody study of your blood. And they found out that in the high school setting, 43% of teachers and 38% of students were infected or had some sign of having been infected by COVID-19. In the elementary schools, 7% of teachers and 9% of students were infected. Again, this is with no precautions, no masking, no physical distancing, nothing. But it teaches us about the difference between the elementary versus high schools. And the implications is that transmission between things, it does seem to happen in the high schools higher than the community rate. But the community prevalence is reflected in elementary school cases. So that teaches us that they're different, and that probably the difference between high schoolers and elementary schoolers probably reflects that ACE2 receptor story and the structure of those classes where high school students mix a lot more, high schools and middle schools tend to mix a lot more than elementary schools. And this is just a picture of what that looks like. You can see these nice clusters of stable groups in the elementary school setting, and then lots and lots of crossover in the high schools. And then what do we know about what not to do? So it's helpful, I think, for sometimes for people to say that I'm not going to do that. So we have a long list of what to do, but I think it's helpful for you to be like, okay, I know, okay, this teaches me this is what not to do. There's a school in high school, middle school in Israel that had an outbreak in mid-May, in late May. They reopened in mid-May. They had over 150 infections, and it was the reason it happened, the story that happened is that they had a heat wave a few days after reopening, and they stopped masking because it was uncomfortable for the students and the teachers. The index cases, the people who had the infection first in that outbreak, were present and they had symptoms. And there was air conditioning going and they had the windows closed. So what does it teach us? That masking, physical distancing, and ventilation are all key, and that symptom screening could have potentially helped. You can see this physical distancing. They didn't use physical distancing in Israel at the time. So we know more now than we did in March. Masks, 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 masks. Physical distancing, stay home when sick and do your screening, and then ventilation and symptomatic and asymptomatic testing and the stable groups. So that just sort of summarizes what we know, and we'll talk more about implementation in a minute. And I just want to, this slide helps us to understand it's a modeling study, meaning it's a study that basically tried to say, you know, if we implemented all these different things, what would be the most effective? So you can see down at the bottom, it's the proportion of each group experiencing symptomatic illness in the fall semester. They did this in the summertime. They were anticipating what it would look like in the fall of 2020. And there's teachers, students, and household members. If you have no additional precautions, you're going to have increased, you're going to have, you know, a proportion of people who have symptomatic illness during the fall semester, elementary, middle school, high school, pretty high proportion in the high school. If you have, here's the testing piece, here's the masking piece, here's reducing contact by stable cohorts, and then here's combinations. You can see that the testing actually moves things, and weekly testing of teachers and students is pretty effective, but masks are actually even more effective, stable cohorts are even more effective, and if you combine them together, they're really effective. So I think it's helpful as we think these things through, where do we invest our time, energy, and resources? It's helpful to sort of see this kind of data. And then the last thing is this is a nice visual about the layers. So if you just have one layer, that's the Swiss cheese model. If you have one layer of Swiss cheese, there's a hole that the virus can get through. If you have another layer of Swiss cheese with a hole in a different orientation, then you can block that one hole. So it's the layers of the Swiss cheese in different orientations that really help to block the viral transmission. And it's helpful to talk about the role of vaccines in that. We have strong enough data on those other safety mitigation layers to say that the vaccines are not necessary to keep a school safe. They are 100% the way we are going to get through this pandemic, but they're not a precondition to being able to have a safe school environment. And so it's important. I always think of it as like, go, 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 go on both of them. So, you know, rolling out vaccines, but at the same time, we can't wait for the schools to reopen because it's not fair to the students, to the teachers, to the school community. So what is the way forward? Data are necessary, but not sufficient. So in the introduction of one of the administrators, I love the quote of, you know, I lead with my heart. And this is a story about not just data and not just mind, but it's hearts and minds about how to help people get back to in-person instruction. Informing teachers, staff, and families about these mitigation layers and that they'll allow for safe schooling is really important, but it's the beginning, and there also needs to be building trust. So a couple things that have come up when I've been talking to people about this for a long time, a couple ideas that have come up, and I'm sure other people have other good ideas, is, you know, a process of co-design can be very helpful for teachers and staff. So not just saying, this is the way it's gonna go, this is what the state says, and this is how we're gonna do it. Sitting down and saying, what do we think is the right way forward for our school to implement these layers? And then for teachers that are worried, actually have other teachers film the classroom setup and show their routines. If they're worried even about coming onto campus, showing people can actually be very powerful. Just, you know, on your iPhone, you just walk around and like show people, what does it look like, the school, look at these desks, and what does it look like in the bathrooms and all that kind of thing. And so the goal is that a sense of calm for people, even if still wary, for teachers and families, they have a sense of control and confidence that the school is a safe environment for themselves and for their children. And the positive messaging is really, really important. So positive reinforcement for masking and school rules rather than punishment if you're not following them, sharing with each other about stresses and successes, as I say at the top, compassion and not contention. Community engagement to build the parent trust, particularly in the communities disproportionately impacted by COVID-19. Commitment to not come to school with symptoms. It's, you know, definitely teachers have said to me, like, parents always send their kids to school with a fever. I don't trust them. So, you know, really articulating, we're not going to do that. And the teachers also say, we're not going to do that. Minimizing the higher risk behavior for families and staff. And then that really important piece about adult to adult transmission, support staff not to transmit by mistake when they're in the break room, when they're doing their interactions, you know, working together. If you want to go quickly, go alone. If you want to go far, go together. This is all about collaboration and working together. And I'll pause there.
Well, thank you so much, Dr. Bardach. And I think we want to go far, so let's go together. Let's take a minute and ask and hopefully answer a few questions. And this is a combination of things that I've seen come up in the Q&A, but also things that people submitted ahead of time. Can you perhaps speak a little bit to an equity lens on the information that you've presented? And I'll give you a couple potential examples. Number one, differences we're seeing in race ethnicity in terms of numbers of cases and severity of disease. But also thinking, how do we help kids in counties who have the highest rates? And are we seeing differences in rural versus urban settings?
Yeah, super important questions. And I talk about those 4 pillars. That's how we sort of first talked about the 4 pillars of the plan from Governor Newsom. I actually think equity is baked into all of those pillars, but we actually I'm working on trying to articulate that even more clearly as a 5th pillar, because we know that it's so important to actually those different, there are so many families who are disproportionately impacted by COVID-19, particularly Latinx and Black families, people of color. And so as we think about how to do school reopening, we have to think about the fact that there's often not enough resources in those communities. So as we think about providing technical assistance, as we think about providing testing capacity, et cetera, we're trying to actually proactively reach out to communities that are disproportionately impacted to try and affect that. There's also, I think, a really important message for families and for school administrators that, you know, as we see these much higher rates in communities of color and poorer communities, how do we interpret that? Because there's one possibility where I've heard families say, well, I think my kid is going to be at higher risk of getting COVID-19. There's something about my kid's body because they're Latinx or because they're Black. So when they walk through that door, they're more likely to get COVID in the school. They're more likely to get COVID than another kid of a different color. And I think it's really important to help talk about structural racism in that situation and say it's actually employment, it's sector driven, that it's people of color tend to be much more frequently the people who have essential jobs who are going out and face to face with the public. And there's a nice study from Kirsten Bivens Domingo at UCSF that illustrates that. And reassure people so it's not that it's physiologically something about them. And then the other thing is that instead of saying, oh my God, those schools have much higher rates, we shouldn't open them. No, we put in more resources towards those schools and support those communities. And then there's the community engagement and trust piece, which is, you know, that's the hearts and minds and talking and building trust with folks.
Thank you. I think I'm going to group my next few questions under the Swiss cheese model heading, because there are a lot of questions about, but what about each layer? So I'll start with one that actually was submitted ahead of time by a participant. So if everybody's wearing masks, are there additive benefits to having plexiglass barriers?
Good question. The plexiglass barriers, we thought in the beginning that they were going to be really important. I would say if you had to choose between plexiglass barriers and improving your ventilation, if you were able to make that choice, and plexiglass barriers cost some money, so it might be that you could put that into ventilation instead. I would do the ventilation instead of the plexiglass barriers. Do the plexiglass barriers add some benefit on top of the masks? Maybe a little bit. But I don't know, Dr. Shafir, you want to weigh in on that one? I
mean, I'd put that in the category of it's not going to hurt. my concern would be if people are relying on the plexiglass barriers, rather, so they can be additive, but I don't think they should be in substitution. So I heard you mention ventilation, and it turns out someone also just posted a question about ventilation. If you have air conditioning, is it enough to have your air conditioning system on in the school? Are open windows better? What about that ventilation layer of cheese?
Yeah, no, great question. And I'll 100% transparency and honesty here is that, I've learned something about ventilation in this job, but I'm not a ventilation expert. So what I would say is it's actually really helpful to have a mechanical engineer or somebody come in, and that's actually part of the recommendation, come in and see if there's anything that can be done to improve the ventilation piece. I will say it's all about air exchanges. So if you don't have air exchange, if the air conditioning is on, but there's no exchange going on, meaning that air is being taken out of a room and fresh air is being brought into a room, that's the air exchange piece, then that's bad. That would be poor ventilation. But if there's good air exchange in and there's good air filtration in the exchange system, then you're okay. And people talk about the filtration needs to be something called MERV 13. But this is where now we've reached the limit of my expertise, and that then implementing that piece is going to be something that that you'll want to talk to somebody with a little bit more expertise about that particular piece. And I will say, we'll plug I believe that there's a plan potentially for a webinar in the future to actually talk more specifically about ventilation.
So we're going to stick with Swiss cheese. And there was a question that came through. Now, I know all the evidence right now suggests that the majority of transmission that occurs happens when two people, an infected person and a susceptible person, are within 6 feet of one another. But we spent a lot of the early pandemic doing a lot of surface cleaning, right? You practically couldn't find a disinfectant in the grocery store. So do you have any thoughts on some of the best practices for cleaning? How often it should be done? Is it different when we're talking about elementary students who are naturally just a little more gross as compared to high school students who are a little bit more likely to be able to transmit? Do you have any thoughts?
Yeah, no.
Don't tell the elementary school students I called them gross. They're cute, really cute. Gross.
You can be cute and gross at the same time. That's cool.
Yeah.
That's why I went into pediatrics. They're cute. It's such an important question, and if you look at the guidance, which I know is like super dense, but there is one page that sort of gives an ordering of importance of things. Cleaning and disinfection is actually pretty low on the list in terms of, and again, there's always this challenge when we talk about the Swiss cheese model. What do we put the most emphasis on? And so we tried to order in the guidance what is the priority order, and the most important piece for the schools. This totally happened in July. We had this huge emphasis on disinfection. Disinfection is like way more complicated than just cleaning. It involves complicated chemicals, and we had all over the place, CDC, California, disinfect all the time. But it's actually A, not good chemicals for the kids, and B, it's a massive resource suck, and it's a total, it was a barrier actually for many schools to open because they didn't feel like they had the janitorial staff. So I encourage people to feel like it is okay. We know that it's actually not about cleaning and disinfecting. Clean, it's good. Clean surfaces, frequently wipe them down. That's fine, but don't do lots and lots of disinfection. And the most important part actually is hand hygiene. So if we can, the thing about cleaning surfaces is that there's viruses that live on the surface. And so if you put your hand on the surface and you put it in your face, or you put it in your mouth or whatever, put it in your nose if you're a kid, then you can get the virus. And so hand hygiene, clean the hands all the time. That will actually take all the burden off of like, how often do I have to clean, et cetera. So that would be where I would say, focus people's energies.
All right, so my last Swiss cheese question, and this is actually, you talked a lot about masks, and clearly a through line to your presentation. But there are some questions about what about special settings? So for example, students in special education for whom it might be more challenging to mask. Does the rest of the Swiss cheese model suffice when there is a lack of masks, or are masks so critical that the rest of the Swiss cheese really hinges upon having everybody in the school situation being masked?
Yeah. I'll answer, and then I'd be curious actually see what you say also, Dr. Shafir. So the what they call sort of harm reduction approach is if the child with special education needs, if they can wear a face shield or something that does a little bit of something to provide some protection from their air particles coming out and being potentially infectious to somebody else, that helps. We talk in the guidance about a face shield with a drape if they can't tolerate the mask actually on their face. There's actually most kids actually can tolerate it. Even children with special healthcare needs often can. So so I think it's helpful to think first about try it. If that doesn't work, face shields with drape, and then 100% those other mitigation strategies will definitely help. I would say emphasize the ventilation and those other things, but that the ventilation and the masking is important.
Yeah, so last question. One of the things that is in the guidance is 6 feet, because that's our evidence base. But if 6 feet isn't possible based on best efforts, you can use 4 feet between students' desks. Is there any data on transmission at 4 feet, or how did that number come about?
Yeah, no, great question. So 6 feet is the standard. It is what we sort of it's what we've seen in both those studies from Wisconsin and North Carolina. They use 6 feet of physical distancing. It's what the CDC points to as also their standard. They don't mention a floor. We decided to say a floor in the January 14th guidance of 4 feet because we had heard that people were actually going much lower than that. So the other piece of data is that the AAP and the WHO, AAP is the American Academy of Pediatrics, and the WHO, the World Health Organization, both say you could also do 3 feet. And there are other countries that are doing 3 feet. So when we were trying to figure out what is our floor in the guidance, we had just started hearing tale of the newer variants. And so we actually decided to go slightly more conservative to the 4 feet. And we don't want to, it's always a problem if you put a number in the guidance, because then it encourages people to be like, oh, I could do 4 feet. And so we wanted to give a floor so that people wouldn't go lower than that. And we chose a floor that was slightly more conservative than the 3 feet, which is the AAP and WHO sort of alternative to the 6 feet generally.
So this will be the last question before we turn it over to our outstanding questions from principals. But last week, the CDC released some updated information from a study about the use of double masks. Do you have any thoughts about the importance of double masking in school situations? Is it double masking for teachers and staff? Do we also encourage double masking for the students? What are your thoughts based on that evidence?
We haven't developed guidance on that yet in terms of how to apply that guidance, how to apply that information to the school setting. So this is just like a practical common sense. This is Naomi Bardach with practical common sense rather than Naomi Bardach state lead for safe schools, if that makes sense to people. Don't say the state lead said this, and so this is just my interpretation of the evidence. And so Dr. Shafir, also interested in what you have to say about this. But I would say for adults who can do the double masking thing, we should probably be doing the double masking thing. We have a variant that does seem to be more transmissible, and it's probably going to be, the CDC said that they think it's going to be a much more common variant by March, and so double masking seems like the right way forward. In students, I don't think it's as clear that the double masks are necessarily indicated, but I feel like the jury's still out on trying to figure that one out, because it's just the same balance. Like, having a kid do 2 masks might be too much for them, and so we might want to just do the harm reduction and have them do at least 1 mask and not have overly high expectations. So.
Great, thank you. Well, I'm very excited right now to turn it over to Susan Montaño, who has the first principle-based question.
Hello, everyone. Great to be here. So this is a question that's on our mind when we meet. We have in Los Angeles Unified, in every school, we have an active COVID task force team, and we meet and review the different manuals and guidelines and watch a module. And so we're always thinking about what's the best way to present this information to 75 plus employees at my school site. And then what's our priority, right? Given the limited time of staff meetings and professional development. And so we're always running into that. So any recommendations that you have?
About the presentation piece of it?
Just what the type of what we should focus on when we are looking at reviewing all this information. What's priority in safely reopening schools?
Yeah. I think it's those, there's a couple of different layers. There's, again, the sort of fact-based thing, the data-based thing, and like, what are the things that we know are the safety layers? So I think providing people some information about what we know about how to keep things safe, but so much of it is sort of which you probably already know better even than I do, like what are the biggest concerns for your communities, it's your teachers, families, and then speak to that. And I continue to try and encourage, and there's actually a nice paper out of the Harvard Global Health about schools and COVID-19 that talk about, the first thing they talk about is trust. Like before any other safety mitigation, trust. And so I would say, start there, and then, you can talk about masks and physical distancing and all that. But I think that's probably the first thing. And then I would say, if you had to prioritize what are the things to like really help people say, these are the most important things, the CDC just came out with guidance and they say masks and physical distancing. So I think that's, that helps to sort of do the priority. I would say from a structural perspective, ventilation is also probably really helpful. And to the extent you can say to people, we know it's important and this is what we did, that'll help the teachers feel like, oh, okay, there's some transparency and there's a system that's thinking about how to do it right.
One thing I would add to that is that we now know when transmission is happening in schools, the vast majority of the time it's happening teacher to teacher. So while what teachers are really concerned about is the risk from students, what we really want them to think about and be mindful of is the way that they're interacting with their peers and their colleagues, because that's likely where we're going to see the greatest risk of COVID transmission. All right, well, thank you. Our next question will come from Miss Yvonne Nelson. Oh, and further answer from Dr. Bardach. And then
layer onto yours, because there's also, I always feel like when we're messaging that to people, I don't want teachers to feel like there's a finger wag. I want it should feel like empowerment. Like I have the power over whether I get infected or not in terms of how I interact with my colleagues, and nobody's going to expect me to be in the break room together with them, right? Rather than being like, it's your guys' fault. So I think that messaging is important. Sometimes I can hear that somebody might hear it that way, and so I would just say that that's the only other thing that I also sometimes try and help. And it's actually super normal human behavior, right? You come out of your classroom, you're tired, you wanted to go chat with your friend, and maybe you take off your mask and you have a snack with them, right? And that's super normal. It happens in a healthcare setting, and we know that's what happens for teachers also. So helping to support them, that's normal, and let's just try not to do it.
I knew I wasn't the only one who was missing donuts in the break room, so good to have that affirmed. Yvonne Nelson for our next question, please.
Good afternoon. I'd like to know if a student or a staff member returns from quarantine, many are concerned about being around that individual. What message could we send to our community to let them know about the science of the incubation period, and is it safe to be around the students and the staff again?
Great question. The risk of getting COVID-19 from somebody who's been cleared to come back after they've done their 10 days of quarantine or their 10 days of isolation, very, 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 very low. And that's just good data from around the country, nationally, internationally. And so the other focus that I've heard from schools is actually helping, when those people come back, helping to decrease the stigma. So, making it clear, like they did their time at home and now they are safe to come back home and safe to come back to school. Dr. Shafir, do you have anything else that you like to say about that?
One of the things that I've found helpful in explaining in my personal circle is, well, now they almost have like a superpower, right? They made it through, they've developed those antibodies. They didn't even have to wait for the vaccine. So the science tells us there is not a real risk, and everything we can do to sort of welcome them back to being in the community once again, and recognizing that it was challenging to be in isolation, and we're really happy to have them back. I think that can all help.
Thank you.
All right, for our next question, we're back to Ms. Montaño.
So I have my special education population in mind. I have a large population, about over 50 students with special needs, mild to severe. And so I just had a lot of questions about how we can protect employees, but also offer a space for students to engage and interact. And sometimes I'm thinking of certain cases where all I know is that they have problems communicating, and they just, the daily interactions, the daily teaching is touching objects. So a lot of questions come up from my special ed team about how we're going to safely reopen with these students in mind. Any advice that you have?
Yeah. So there's touching objects, and then there's touching other people. The touching of the objects, I think the answer about we can worry a little bit less about the touching of objects and actually people passing the virus by touching an object and then somebody else touching that object and getting the virus. So that one piece potentially is helpful. You know, to the extent the staff wants to wipe something down, if it's going to another student or that they're touching it, or, you know, that's totally reasonable, but there doesn't have to be lots of disinfection and a lot of anxiety. It's hard to be a teacher and be stressed all the time that you're constantly trying to figure out, well, clean that, right? So, so that's one piece. And then there's touching other people. And so it might be that there needs to be clearer physical situations where the students can go touch more people in an outside setting, or if they're touching somebody, they can, you know, do it from the side instead of doing it, you know, full frontal. And that there's also the issue is the length of time that you're exposed, in addition to how close you are, right? So if there's a long time of being close to somebody, that increases the chances of having that transmission. But if it's just a little bit and the student can get a little bit of grounding, you know, by having a physical experience, then, you know, it's the accumulation over time that you want to be thinking about.
Thank you. And back to Ms. Nelson for the next question.
So my next question is in regards to masks. The August 2020 guidance mentioned that it strongly recommends, but is not a requirement, to wear a mask for a second grader or below. If there are any students in this age group who refuse to wear a mask, what message should we tell the families who are worried about their child's safety who are wearing masks?
Yeah. So there's a couple of things. The January 14th guidance actually changed that, and reflecting the more national also guidance that even kids as young as preschool can wear masks. And so it's now a requirement for preschool and older to be wearing the masks. So that's one piece. Doesn't mean that there won't still be a student who says, I can't do it. So I think that just has to do with how do you deal with that on a school policy level. I would encourage people for equity reasons, as well as just for general, you know, helping the community to do less penalization and more encouragement of that behavior. So, you know, rewards for kids who do a lot of masking, or for groups of kids who do a lot of masking, you know, what I like to say, point positive, right? Rather than say that's really bad. The things to encourage families who are worried about another student, that part is a little complicated, because I think I would probably start with those other things first. And hopefully our experience so far, generally speaking, is that most kids are actually pretty good at it. They need reminders, but it's usually not a wholehearted refusal. And sorry, the one other really also useful tip that you guys might already have totally heard of, but you can also do mask breaks. So there's a chair, you know, outside where a kid can take off their mask and sit there for 10 minutes and like just not have to deal with it for a bit. So that's the other way that a lot of schools have been doing. So.
Great. Thank you.
Yeah.
Love that idea. If I had been an elementary school student as an introvert who didn't really be around other people, I'd be like, I need a mask break. You just got back, Shira. I need another mask break and I gotta go outside. So I think, Ms. Montaño, we've got time for one more question from you, please.
Something that also has been coming to mind is our families in South Los Angeles live in really small spaces. And it's when we're talking about isolation and quarantine, I don't know if it's like my Spanish ability to not be able to explain or, you know, my language skills, but I always run into that problem where explaining the difference between isolation and quarantine.
Mm-hmm.
Any tips that you have, advice?
Mm. Yeah, I think it's a challenge for everybody, no matter what language you're in. It's very complicated to wrap your head around it. And so, you know, it's this idea that if you're isolating, it means that you are that somebody has an infection. So the isolation is try to put them in a space where they're less likely to give the infection to somebody else. It's hard with kids to do that. So I actually feel like sometimes it might just not be possible for that kid to isolate at home. And then you might then just treat it as sort of everybody's quarantining at home, that you don't think that the kid is infectious, or you don't think the staff member is infectious. You're infected. You don't think that the kid is infected or that the staff member is infected, but there's some chance that they got exposed. And so they're staying at home. That's the quarantine sort of, it's the watching. Quarantine is like watching. Isolating is, you know, you're infected, and so you're trying to separate off. Quarantine is like a watching period. You're sort of staying at home and checking. Am I going to get infected or am I not going to get infected? And so then it's just, you know, the rules are a little bit more relaxed. You might want to still try to stay a little bit apart, but there's no obvious sign that you definitely have it. So the rules are a little bit different. I don't know, Dr. Shafir, do you have any other helpful ways of explaining?
I'm not sure how much it helps, but I've been teaching epidemiology for graduate students in public health for about a decade now, and I spend a lot of time in lecture talking about them and how they're different. And I still have half the students getting the question wrong on the midterm. So I'd like to say that's not me and my teaching. It's actually, they're really tough concepts. At the core of both of them is we're trying to stop the infection from spreading further. And so that means we're asking people to change their behaviors if they are infected, or there's a chance that there might be. And maybe just breaking it down and focusing less on, are we calling it quarantine? Are we calling it isolation? And just saying, these are things we're asking people to do to stop the virus from spreading. Well, thank you to both of you. It was such a pleasure to know the actual questions that people are getting. And now I'm just going to quickly go to the Q&A and see if there are questions that we can answer. You know, one of the themes that seems to be coming up in a lot of the questions, and I apologize that we're not going to have time to get to every question, but it really, it highlights what Ms. Montaño already asked about. Special education settings and circumstances where students do have different needs in the classroom and different circumstances. So I guess one question might be, will there be any specific recommendations coming forward for special education settings? And if not, what are some of the most important things to think about in these settings, particularly when there are students with special needs who might be aggressive, which would then mean very close contact between the student and the staff, or students who need hand-over-hand support to access curriculum. So now you essentially have that, the pod of the teacher plus student. Any thoughts or light you can shine on those specific scenarios?
So we have talked about trying to do guidance for special ed. I think it's been a challenge always because each scenario is potentially a little bit different. I think the physically aggressive scenario, that's a super hard one. I think it kind of depends on if you know that your student is, you know, has a high risk of physical aggression. That might be a situation where you might want to have the student do more distance learning. Because then you can have a little bit more separation. But like I said, it kind of depends on the trigger for the student and what the kind of capacity we have. So that's one piece. And then the hand-in-hand support, there is some part of the guidance that sort of talks about you can do one-to-one specialized services, and it talks about how you have to follow the industry guidance for specialized services, and it has some description about how to do that safely. And there shouldn't be another student involved when there's just a one-to-one. That teacher can actually go from one person to another person, like sometimes it's like one student in class and another student in a class. And so the question is that okay if this teacher crossing cohorts and whatever? But the guidance says if it's just one-on-one in a separate space with that student, then that's okay. So things like that are in that guidance.
And then the last question I think we'll have time for from participants. This seems like it's really stressful. It's stressful for the families who are coming back in person. It's stressful for the administrators, and it's obviously stressful for the teachers. Do you have any thoughts or advice about what administrators can say to teachers as they're feeling so much stress and pressure on top of the year's worth of stress and pressure that they've already been feeling?
Mm-hmm. Mm-hmm. I think that's for wiser
You'll
people.
notice I asked it so I didn't have to answer.
Yeah, that's right. Yeah, exactly. I mean, this is where I do keep on saying we're in it together. The enemy is COVID-19, and we're in it together to try and mitigate those effects as much as possible. I appreciate the question in the chat, which says, I love being with my students, but it's stressful for me, right? And so holding both of those truths at the same time, and allowing for that to be a reality, and people that talk about it, is I think really important. And I think as much as we can name those things and not ignore them, right? That's the biggest problem with this pandemic, is if we ignore the emotional experiences that are making it hard, then it's actually much harder to do. So I think from the leadership perspective, I think talking about that emotion is actually really important. But I'd be curious actually to see if Ms. Montaño and Ms. Nelson have something to add about what they have found to be effective messages.
I have to read the room at all times, know my staff and know how they're feeling. And then as a leadership team, we pause and we open and discuss, what have you heard? What do you see? What do you know? Sometimes teachers are not open to tell me how exhausted and stressed out they are. So I just have to make myself available and make my team available to then problem solve and try to assist, but it is very overwhelming. So right there with you.
I think we've really tried to work on being a strong team and leaning on each other. Just like you said, naming some of the fears and trying to outline some of the things that we're concerned about as we move forward, and just work together as a team, because I think an added thing to stress is being overworked and tired. And so the more we can work together as a team and share the wealth of the work, the better we are as a school community.
I will say thank you to everybody for your clear and candid responses and answers. And now I'll turn it back over to Dr. Dorian.
Thank you so much. And I want to say also, administrators, I understand how much you're going through. So just really knowing that we're there for you as well is important. And it comes back to sort of Naomi's thing, we're all in it together, right? And really how we can help each other, because ultimately we want to open and we want our schools to come back. So really thinking about what we need to do. So thank you very much to our esteemed panelists for all of your incredible wisdom and insight. As I mentioned in the beginning of the webinar, today is just the second in a series of webinars that we have coming up, all of them hosted for school administrators to create this forum so we can dialogue and work with subject matter experts in thinking about how to turn the guidance into true operationalized programming with the specific needs and realities within our schools. The next one coming up is Thursday, February 25th from 4 to 5 p.m. And we're going to focus on school-based exposure management, contact tracing, case investigation, the decision tree, right? All of those things that we need to think about in opening the schools, followed by school-based testing, equity in schools during COVID. And we'll continue this series as we look at your questions, answers, comments. So please continue to write to us. We'll also do our best to answer all of your questions that we weren't able to answer today in our upcoming FAQs. I want to thank you all again for being here, and we'll see you all next week.